Hi everyone, my name is Catherine and I'm here to present my project. So starting off, I currently work in a 39-bed ICU unit that holds a combination of medical and surgical patients. So most of these patients are hemodynamically unstable and a number do not leave the ICU the same person they were prior to admission. So I chose to focus on this population because I closely work with them. Selected population for this research study is going to be any adult going into this ICU that requires ICU care 24 hours or more. So, according to studies, there are long term consequences of ICU care in the physical and mental health of patients. This includes, but not limited to, cognitive decline, PTSD, and depression. The location chosen will be my workplace, since I hope to push for better policies in our unit to increase not only patient safety and satisfaction, but also the morale of everyone working there. So, the ICU that I work in is currently a closed unit allowing 2 visitors at a time and discourages visits throughout specific times of the day due to implementation of quiet hours, which is couple hours in the daytime and couple hours in the nighttime. So, in order to provide holistic and patient-centered care, patients often will benefit from a support person in order to help with their healing and mental health. So, ICU is a perfect environment for developing delirium and cognitive decline. Patients lose track of night and day. They follow strict routines. They hear different alarms going off at every given time, and many of the members of the healthcare team visits them throughout the night and day. The AACN states that flexible visitation decreases the length of ICU stay, increases patient satisfaction, decreases anxiety, confusion, and agitation, and increases quality and safety. So, unrestricting visitation hours is one of the ways that we can help the patient's well-being and aid in their recovery and hopefully downgrade them from the ICU. And I believe more hospitals should implement this system as it benefits the patients in the long run, and I would like to start in the unit that I work in. So there are multiple evidence-based procedures on how to decrease ICU delirium, and one of these is having an open visitation environment. So open visiting reduces stress and leads to tranquility and thus helps patients to rest. Different studies have shown not only there has been no increase in cardiovascular indicators such as high blood pressure, heart rate, and decrease in oxygenation in patients having visitors, but in fact was considerably lower and had no destructive physiological effect on the patients. So, as a paradigm shift of healthcare focuses on patient and family centered care, I believe the ICU units should have set policies and guidelines on how to reduce the healthcare team's apprehension on open visitation and address nurses' concerns. So the first implementation that I would like is to incorporate the ABCDEF bundle. So this is a tool that a lot of ICUs have. It's an evidence-based practice tool that helps patients to liberate from the ICU, get them off the ventilator, and get them home. So one of the parts of this bundle encourages and promotes families at bedside, and ICU should not be a hindrance for something that will be beneficial for the patients. Flexible visiting hours for support persons is one way that delirium can be avoided and decrease the length of stay. It can be assumed that flexible visiting policies can have a positive effect on the patient's condition and promote family engagement. This includes non-pharmacologic interventions for delirium prevention, such as reorientation activities, reestablishment of a familiar environment, and cognitive stimulation. It is encouraged to stay away from sedation or choose a specific sedation medicine that does not affect the patient's cognitive status that much. So, being that ICU patients are hemodynamically unstable, nothing's working right, it's some of them takes a long time to wake up because of the metabolic status of these patients. So open visitation policies increases the opportunity for family members or a support person to be at bedside with the patient and be a surrogate decision maker if they need to be. Critical care units should adopt the open visitation system to provide holistic care effectively. So my plan is for this to be implemented is to work closely with a critical care director, my mentors, and my ICU manager, and also the charge nurses and the clin soups to brainstorm to how to honor privacy and be respectful of other patients in the unit. Patients, families, nurses, and other members of the healthcare team can reevaluate and modify the presence of and participation of families based upon safety criteria. So a lot of the apprehension of having an open visitation policy is because it's going to be a lot more traffic in the unit, as much like we don't need a lot of people going in and out of the ICU. So this is a nurse driven thing. Nurses usually tend to protect their patients, and they don't like anyone going in and out of the room for no reason. So also another tool that I would like to focus on is the confusion assessment method for ICU, also known as the CAM ICU, which is a screening tool for delirium. And I believe that this is not, I just started working in the ICU and it didn't really have much training on how to assess patients on this. So I would like to bring more focus and re-educate everyone in the unit so we can intervene once those early signs are found. So it is used to assess level of consciousness for every patient, and a decision is made as to whether the patient should be further assessed or it can be reevaluated later. So during this time frame, within a 4-week period, I would like to implement the CAM ICU and the ABCDEF bundle to keep track of average times that families at bedside, and also interview families regarding about their perception of care and mentation baseline of patients to see if anything changed. So this ABCDF bundle, A means to assess, prevent, and manage pain. B for spontaneous awakening and spontaneous breathing trials. C stands for choice of analgesia and sedation. D is to assess, prevent, and manage delirium. E is early mobility and exercise, and F stands for family engagement and empowerment. So again, this is an evidence-based practice approach to eliminate the decrease of incidence of delirium, and it just needs to be educated to the nurses and all the members of the healthcare team in the ICU. So again, CAM ICU and ABCDF bundle should be taught in mandatory education and training for the staff, which we hold every month anyway. So I believe that would be a perfect time for everyone to gather and bring out their opinions about it. Let's see, and also this would be a perfect time for all the evidence-based practice and literature to be presented to the staff and why we need this open visitation policy. So most of the findings of my literature review show that open visitation is beneficial to the patient, and this includes flexible visitation hours for support persons, having a support person there readily available for the patient with no time constraints or limitations can help the incidence of ICU delirium. The patient's families can be a valuable resource to engage when implementing delirium prevention activities in the ICU. In this study, healthcare providers stated that they are usually too busy to perform delirium activities, but most family members states that they don't mind doing this. So that's another way for family to be on board with a plan of care. So another study showed that the challenges faced in adopting an open visitation policy is presented as four major themes, and this is negative staff perceptions and attitudes, patient protection, family and cultural consideration, and organizational challenges. Um, Next, studies show that physiological indices of the patients, including systolic and diastolic blood pressure, heart rate, body temperature, respiratory rate, and arterial oxygen saturation, were compared before visitation, after, and during, and the results of the test were indicative of no statistically significant difference in the physiological indices of patients during these times. Another study showed the critical care setting may expose family members to a variety of stressors, such as miscommunication, uncertainty about patient survival, rehabilitation, and lack of support for shared decisions. Open visitation includes the family in the plan of care and provides them with reassurance and support. Next one states that patient-centered care is an expectation among patients, families, and health quality advocates. These expectations include effective communication, convenience, and flexibility of visiting times in building trust and confidence with the family. And the last literature review that I found states that extended visitation favors patient and family-centered care and promotes family engagement in the care of the ICU patient. This routine may improve communication between patients and ICU staff and providing a better understanding of patient risk factors for delirium. This study also states that patient stress and anxiety may be reduced and patient reorientation may be optimized while reassurance and comfort measures are promoted and treatment adherence is enforced. So current practice is that we have a close unit that has specific visitation times and limits on who can visit. Evidence-based practice, however, states that there is no difference between physiological factors between patients who are in open visitation and closed visitation units. So from what I've seen is that current practice in my unit has just been a long tradition and deeply rooted culture that nurses have enforced. I can see the reasoning behind this. It's due to the fact that ICU patients are unstable and it is thought that family can get in the way of nursing care. I've seen this happen, especially if the patient is very unstable. We have to start a lot of things fairly quickly. It can be a hindrance to have extra people in the room, especially if family doesn't know what's going on. So, but I believe that we just have to communicate to the family as best as we can when doing our nursing care. We can do our job first and then explain to them what we did after this is done, because our priority right now is to stabilize the patient. But having them there at bedside is really helpful sometimes, especially when we need more information regarding the patient's health history or what makes the patient more comfortable. So studies have shown that having them at the bedside can help in the non-pharmacologic ways to decrease delirium, such as reduction of pain, reorientation activities, establishment of a familiar environment, and prevention of sensory deprivation. So to conclude, as we move to holistic patient and family-centered care, believe that ICU units should have set policies and guidelines on how to reduce the healthcare team's apprehension on open visitation and address nurses' concerns about it. Incorporating the ABCDF bundle in the unit encourages and promotes families at bedside, and ICU should not be a hindrance to something that will be beneficial for the patient. So flexible visiting hours for support persons is one way that delirium can be avoided and decrease the length of stay and poor outcomes that may happen. So the best we can do as healthcare providers is to incorporate best practice and continuously find better ways to decrease the risk of delirium in the ICU and poor outcomes.